Welcome to a talk about prostate cancer. This was originally a talk for medical students, but I think it would be suitable for multiple professional groups. I'm going to do this talk in between cases, so I'll be coming and going a bit, but hopefully you're sat in a more comfortable situation and you've got yourself a cup of coffee and can relax. I'm going to split it up into a number of talks, probably 3 or 4 little episodes, and then we'll upload it to YouTube and you can watch it in digestible chunks, I hope. So to get started, my name is Mike Henley and I'm a consultant urologist in Derby, and this isn't a fully exhaustive talk, but just really a grounding in prostate cancer. So as surgeons, we're all really rather competitive people, so we all like to boast a bit, and all surgeons say when they're talking about their cancer is the cancer I deal with is bigger than yours, and that is certainly the case for prostate cancer, no doubts about it. Commonest cancer in men, and the second highest cause of cancer death in men, so that's a very significant issue. To understand the effect of prostate cancer, we need to look a little bit at the anatomy, and here's a drawing from a textbook, and it's worth just having a look here at the cross-section. So there's the bladder in the pelvis, there's the pubic bone and the penis here, and the rectum around here. So there's the bladder, beneath the bladder is the prostate, and the urethra comes down through here and then out through the penis. So you can see the prostate's close to lots of structures, right next to the rectum, right next to the bladder, and also there's a little run of nerves here, cavernous nerves, and these are the nerves that provide erections. So you can see there's a lot that could be damaged during the course of surgery or radiotherapy or any other energy technique to treat prostate cancer. So where within the prostate does the cancer arise? Well, here's a traditional drawing of the prostate. And the tissue of the prostate grows around in layers, a bit like an onion. The central, this piece here, point against, this transition zone tends to be an area where patients get benign prostate disease. But out here in the peripheral zone tends to be where the prostate cancer occurs. And this is the bit that on that other drawing, if I go back one, this is the bit that abuts to the rectum here. That's exactly the point. So this is why clinical people, doctors, etc., examine the prostate through the back passage. You are going to pick up a lot of the prostate cancers. Not always, sometimes they can be anterior cancers up here, which is one of the reasons why there are newer techniques for doing biopsies. So what's the prostate for? What's it all about? It produces a little bit of fluid in the ejaculate. It's got high levels of zinc within it, so it's probably about helping sperm function. High levels of citrate, and that's possibly for the optimal pH for acid phosphatase. What semen is actually a slow release mechanism for sperm, and one of the chemicals is designed to split the viscid bits of sperm and release the sperm gradually. So the prostate's made up of 2 bits of tissue really, stroma, which contains the gland, and muscle. So the stroma is to produce the fluid, and the muscle is to basically get the fluid out, nice and straightforward. In addition, at the neck of the bladder, it's to produce antegrade ejaculation. There are other things the prostate probably does. It might be protective against infections, but many of these thoughts are experimental rather than anything else. PSA is a big topic within urology. It stands for prostate-specific antigen, although patients do sometimes tell me it stands for patient-scaring antigen. It's actually a serine protease, so it's designed to liquefy semen. That's its job in life. And it can get into the blood. Some leaches in from benign tissue, but also from malignant tissue, higher levels leach in. The glands aren't properly organised, so rather than the fluid getting out and getting into the semen, it manages to get into the bloodstream instead. So for every gram of cancerous tissue, you'll have a higher PSA than you would with benign tissue. Can it be used for screening is a question that people often ask. So to answer that, we're going to use Wilson's criteria for screening tests. So the first thing is the condition should be an important health problem. Well, we can confirm that with prostate cancer. The natural history of the condition should be understood. I think that's probably the case. There should be a recognisable latent or early symptomatic stage. Yes, I'd say that's probably true. There should be a test that's easy to perform and interpret, acceptable, accurate, reliable, sensitive and specific. It would be the case if the blood test was the test, but it's not. The actual test is a biopsy, and we'll come to that shortly, but you will see then that actually it isn't really acceptable, I would say. There should be an accepted treatment recognised for the disease. Yes, but there's some arguments about those. Treatment should be more effective if started early. You would have thought that was straightforward and sensible, but actually it's harder to prove with prostate cancer than you think, and even still, large numbers of men need to be treated to make a difference. So that is slightly marginal. There should be a policy on who should be treated. We still argue about that widely. And then finally, case finding should be a continuous process. All that means is you should, once you've started a screening program, you should carry on. So we're going to look at prostate cancer in a bit more detail. So I'd like you to gird up your loins and tell me out loud to the computer what percentage of men aged 80 have prostate cancer in the UK. Go on, give it a go. And the answer is 80%. So it's a very, very common disease. What percentage of California men aged 30 to 40 have the precursors of prostate cancer? In autopsy studies, 30%. It's quite common as a kind of precursor disease even in younger men. What percentage of men die in their 80s with prostate cancer? So we knew that 80% have it. How many die from it? Only 3%. So there's a lot of disease around, but not everyone's going to die from it. And that's a really critical point to understand with prostate cancer. Over-treatment is an ever-present potential issue. So to look at raw numbers, these are the UK figures. They're not very recent, I'm afraid. But here we have crude rate per 100,000. It's still about 100 men per 100,000 men. So a significant disease. And what's more, there appears to be an epidemic of prostate cancer. Here's the incidence line. Daily Mail would definitely call it an epidemic. You can see here that mortality is staying fairly flat, and the more recent figures, it's tailed off slightly. Why is that? Well, if we look back here, this is when we started measuring PSA. And this measurement of PSA corresponds totally to the increase in incidence, and it's about finding the patients more easily. To give you some context, these are some figures for heart disease. These are Glasgow figures for heart disease, 250 per 100,000 for heart disease in Glasgow, and over 100 per 100,000 men with prostate cancer. So you can see it is a common disease. As we've seen, it increases with age. The only urological cancer that decreases with age is testicular cancer, a disease predominantly of young men. So it's hardly ever occurs before the age of 45. Rare in men in their 50s, very common in the 80s, and everything in between. No women can't get prostate cancer. In a survey, they asked the public whether women had a prostate, and about 50% think they have one, but it's very, very small. No, women haven't got a prostate. So where is the highest incidence? Which group, which racial group, or which group of people have the highest incidence on the planet? It's black Americans. And the lowest incidence, give it a guess again, Chinese. Does migration make a difference? Yes, it does. So if you're Chinese and then you move to the Bronx, you will start to develop the risk of a black American. So some of it may well be environmental. And you can see there is a huge difference in the incidence of prostate cancer. Very low. Countries like India and Japan and China, and then becoming very high in places like America and Scandinavia. And here's the UK pretty much in the middle, but still a significant problem. What are the predisposing factors? Diet high in dairy products. I know this is probably news to a lot of people, but milk is a drink designed for baby cows, not people. And therefore, milk contains a lot of growth factors. Now, there is argument about whether those growth factors are absorbed. They may not be absorbed, but regardless, it stimulates growth factors anyway in people that consume it. So if you measure people's blood after they've been drinking milk or eating dairy products, their growth factors go up. And for men, that probably stimulates prostate cancer, and for women, it stimulates breast cancer. So dairy products are not so great in that respect. It differs depending on the kind of food you're eating. So hard cheeses aren't so bad, milk's the worst, and of course things like cream and Greek yogurt are in between. Traditionally we'd say no, vasectomy doesn't increase the risk, but there was a recent paper which suggested that it does. We've got papers in both directions. Certainly having first order relatives diagnosed with prostate cancer will increase your risk of prostate disease, and there are a number of syndromes such as Lynch syndrome where it's more common, people with breast cancer, and also if you've got a relative who's got breast and ovarian cancer. So if you're one of those families, your rate of prostate cancer is 9 times higher, so very significant. What can you do to avoid it? Usually people only ask me that after they've been diagnosed with it, But soybeans, brassica, legumes, all of these things are high in phytoestrogens, and they seem to reduce your incidence of prostate cancer. And that may be some of the protection of people in Asia, is that they tend to eat lots of foods with phytoestrogens in, and they don't tend to consume dairy products. Obviously things change as countries change. And tomatoes, as per usual, via lycopene, are good for your prostate. Selenium is also good, so you need to get your hands on some of those Brazil nuts. So let's have a little bit of a look at pathology. So here is some normal prostate tissue, and just to point it out to you, earlier on I said there's some stroma with smooth muscle, there it is, and there's some glandular tissue in there, that is, and you can see that there's stroma there. These are nice little cells, well behaved, nicely organised duct there, gland. And then if we look here at some prostate cancer, it certainly looks different. So you've got much larger cells, large nuclei which show up very well and very densely packed. That's not right. Now you'll see letters go out about patients with prostate cancer. As surgeons, what we do with or any doctor with a patient with cancer is we grade and stage the patient. So the grading is a system called Gleason, and Gleason was an American pathologist. The reason we need this complex bit of staging is that prostate cancer is often multifocal, so it's not just one bit of cancer in the prostate. And often a patient will have a couple of different areas of prostate cancer which may be of different severity. So what he did was he looked under the microscope at the different areas of cancer, and he gave them a mark out of 5 for evilness. So if they were very evil, they got a 5. If they were pretty fluffy, they got a 1. And in the end, after looking back at how well the patients did, it appeared that the best thing to do was to look at the 2 commonest areas and see what their mark was, add them together, get a mark out of 10. So 1's well differentiated, and the most highest you can get is 10, and the so well differentiated is about 6, moderately differentiated 7, and the others are poorly differentiated, and they are closely related to prognosis. So the next section is going to be spread and how it might spread, but we're up against nearly the 15-minute limit on YouTube, so I suggest you get yourself another cup of coffee if it's run out, and I'll be back in a second.